All right. Hello, everyone, and welcome to our presentation. We're very glad to be here. Before we start, I just wanted to do a quick icebreaker, and we can't talk with each other, but just for you to think about. So, if you had to choose a few characteristics that you think should be taught in medical schools and medical education for what future healthcare interactions should be, what characteristics would you think are so important that physicians, that patients have so that we can have a solid healthcare system in the future? And we'll come back to this a bit later on. So that we can move on.
Really
Let's
quickly, Ali, can you do a self-description?
Oh yes, yes. I am a South Asian male who is wearing a gray suit. So we have no conflicts of interest, acknowledgements um, for all the participants and the volunteers. These are our objectives. Dr. Cam, do you want to start with the objectives?
Sure. Thank you so much, Ali. So we have three main objectives for today, aligned with the conference theme in terms of how we integrate some of the technology, particularly artificial intelligence. We have this human-centered co-design model that we want to present to you. And then we subsequently link it to how that related to artificial intelligence and how that linked to knowledge translation.
Right.
So in this human-centered co-design model, we actually trying to link undergraduate medical education, postgraduate medical education, as well as continuing professional development, practicing physicians, allied health professionals, as well as patient and caregivers, all together in this equity learning health system. So in this manner, we actually be able to identify some of the knowledge gap that we identified. Thank you. So in our earlier study, we actually identified the knowledge breakdown in terms of not having learner being co-leaders and not having patient and caregivers as co-leader in our previous model. And that's how we subsequently improve on it and linking it to what I call strategic planning. So when we talk about strategic planning, it's interesting, even Harvard is saying that plan and strategies, but they never go together in many ways because strategies is what the theories that we believe in. And plan is like what the outcome that we want to see. So the outcome that we want to see is like we want to promote equity. We want to have everyone to be on the same table in terms of this technology development. But what strategies we're going to do? So this is what we're going to present to you. So in our study, we collaborate with a group of healthcare professionals, patients and caregivers. They wear many hats. Some of them, they are academic directors, leaders. Some of them, they're teachers, allied health professionals, policymakers, as well as researchers. In this space, we always included patient and caregivers in this model as well, and so that they can help us to create a rubric in terms of identify what compassionate care is. Next slide. So at the beginning, we try to co-design and asking them what kind of knowledge product they want to see on the website. So this is some of the things that they identify. They really want infographic, they really want videos. That's how we created our website. Next slide. In the research methodology, we are focusing on qualitative study. We run 2 focus group and 1 individual interview. And we subsequently do thematic analysis, qualitative interpretive analysis. So the methodology that we use is we center on this cultural historical activity theory. In this theory, there's subject such as how patients and caregiver would like to receive the concussion care. And instrument is how they accept to change or how they come up in terms of a new solution for them. Object is how to navigate the concussion care system. Rules are the system limitations. Community could be their friends and support network. Division of labors could be like anyone in this interprofessional team spectrum is what OT is going to do, what PT is going to do, what all your healthcare providers are going to do. Of course, the outcome we always want patient to get better. So that's what the ultimate outcome is. In this learning process, we start from questioning and trying to find out a new solution and find out new models and reflecting to the past, and subsequently we drive for new learning. So some of the results that I would like to share with you. So you can see that the results from our patient and caregivers, as well as from our allied health team, is that when they see the moments of compassionate care action, what they identify is that they want to have specific goals and recommendations that really tailor to their individual needs. And when their plan change, they actually identify that they try to celebrate for small steps. They try to change slightly of their directions and also give space to allow them to readjust. So in this system activity model that you see, patient and caregivers, they identify some of the contradictions, such as the rules and object. Sometimes the object is we want to be understood, but then the rules in the system may not allow us to be understood. And in the activity system of the clinician and leader team, they also identify that, the rules are more standardized care, that they're trying to follow the rules. That's what they were given to. But at the end, they are trying to drive for patient-centered care as well. So that's really a contradiction that they're trying to overcome. Some of other contradictions are such power hierarchy. They have hesitancy to contradicting to professionals. I don't know if this is going to work in my case because X and Y, and And also another level of contradictions is acceptance. It's very hard to accept a new change, and we all need to give space for, and getting to a place where I could not feel I'm guilty to take rest anymore. So there's a new level of change. In terms of some of the contradictions that I mentioned earlier, power dynamic, as well internal barrier of accepting support, and that's how they lead to coming up with their adaptations. How they adapt to it is they try to change the way that they do things. So from the clinician and leader team, they're also trying to adapt to the system. The system is not perfect for them. They try to learn from the system, try to provide, the best care, the personalized care. And so they use the knowledge that they have, trying to adapt to this new standardization for change. What I end up learning from all of my, expert patient and caregivers, as well as allied health team experts, is that they really identify that the most compassionate concussion care for them is when they don't need me anymore, when they can be independent, having the autonomy. And having the confidence to speak up, stand up for yourself in little ways and big ways. Together, the whole team actually come up with a new definition of compassionate concussion care. They identify that they need to be having this co-leadership, transformative agency, more system approach to learn how to adapt, how to create new meanings, also co-creation approach in terms of how patient-centered care should actually be in this space. So together, they come up with this new rubric in terms of how this rubric can be integrated into AI model. So this rubric that they identify is that 3 big themes. One big theme is patient priorities is the number 1. Adaptability and responsibilities is number 2. Agency and enabling practice is more than important and is absolutely necessary in this AI building model. So together, we work with, the whole team. We develop this reflective learning model, integrating with AI to really foster compassionate care practice. Now, this is how I am talking about in terms of strategic planning. There's no such thing called strategic planning here. But when we start with an education problem, such as concussion care, we try to find a theories, find a design. The design that we use here is co-design model. The theories that we use here is cultural historical activity theories to identify the know-do gap, as well as to improve on the engagement, change the culture to achieve our quadruple aims. This is a pilot study in a 5-year study, a bigger size study that I'm happy to discuss with you later on. So this co-design model really trying to augment in terms of what AI can do. Okay, and this bigger size project is a spiral co-designed approach.
Okay, so this is Ali Kasim again, a South Asian male wearing a gray suit. So let's go. I want to just generalize Dr. Kam's presentation as well and apply it to all of healthcare. So what we can see is when we were trying to generalize this, and also when we were trying to answer the question that I posed earlier, what characteristics would we want in the future of healthcare? What key values would define it? We found ourselves constantly coming back to this idea of patients and physicians working together in a partnership. And I really want to elaborate this a bit further. And we also are very fortunate to have one of our patient mentors who has gone through the health system in Canada to give his own feedback as well. So this is our broad model and our vision. So there's a physician-patient partnership. The physician or the healthcare provider walks into the room. They walks into the patient room, and they're able to build rapport. The patient's able to feel like they can trust the provider, and this allows them to be empowered. The patient then feels like they are leaders in their own health, and they can advocate for themselves. This leads to health impact, and eventually the physician and the patient take the story of this very successful encounter in which there were real health outcomes that happened, and they're able to disseminate that knowledge to the rest of to their peers and help this model progress. So what I'll do is I'll first describe a little bit about why patient-provider partnerships are necessary, and then we'll go into the key characteristics that would define each stage of the patient-provider partnership that we just discussed in the last slide. So patients, from their perspective, they feel safe, respected, and they feel open to sharing when they feel like they're in a partnership with the physician to guide their healthcare decisions. So, for example, if they are strong advocates or they're strong believers in not taking medications and maybe doing lifestyle measures, if they feel like they're able to communicate that to their physician, and the physician is open to actually trying those methods before just prescribing them a pill, the patient feels a lot safer and they feel like they can actually heal because they're being listened to. From a provider perspective, they can understand patients better and collaborate on care. If a provider comes into the patient room and just is on their computer documenting, I'm sure, unfortunately, we've all had that kind of experience. The provider doesn't really get to know the patient. The patient doesn't feel like opening up because they're like, the provider doesn't care to listen to my story. And as a result, there's these key ideals that fall through the cracks. And then the last is the outcome. Partnerships built on trust drive shared decision making and improve health outcomes. And this is the same as what we have said before. So let's go into a few characteristics that define our model. And we thought of communication and self-agency as extremely important and worthy of further elaboration. So communication. Why do we say good communication is the first step towards partnership? Because active listening, empathy, And openness on the part of the provider makes a patient feel valued, and that leads to meaningful and productive interactions, i.e., outcomes follow, real outcomes, the patient experiences. And this is so important. So this is from the perspective of the provider. However, we also need to make sure that we take the patient's perspective on communication. So I'd like to welcome Charlie, one of the co-presenters, and I'll ask him a few questions about how communication has helped or perhaps not helped in his interactions with the healthcare system. So, first question for you, Charlie. Can you tell me about a time when a doctor or a nurse or a healthcare provider really made you feel heard or understood?
Yeah, absolutely. So in my experience, I've been in the healthcare system for a lot of years since I was a child. But mostly in the past 4 years since my injury, I've really been, experiencing the healthcare system. And so the first thing that comes to mind when I think of a time when, I was really listened to and heard, was the first time I went to my third concussion clinic, actually. I had a conversation with the doctor, and the first thing they asked was, "What do you want out of your care? What are your goals?" And it really, made me think of my care in a different way, and really kind of believe that, I could drive my care in the direction that I wanted and that I needed.
Thank you, Charlie. This really helps us with understanding what good communication feels like, and it seemed like that was there. The second question, what kinds of things do healthcare workers say or do that help you feel comfortable and supported during an appointment?
Yeah, so for me, I find when doctors are facing the patient, when I'm really face to face with a doctor, that makes me feel really comfortable, a lot calmer because I feel like I'm having a conversation with a person instead of somebody who's in a position of power over me. And also to really take time and slow down when talking, especially for me as somebody who has difficulty processing information. And so, really having that kind of face to face conversation has always been very helpful.
Thank you for sharing. Has there ever been a time when communication didn't go so well? And what would have made it better for you?
Yeah, absolutely. So I had a really poor experience with my first concussion clinic. They were more interested in furthering their own research than actually helping patients. And so they tried to push me into one of their studies, even though it was just a few months after my concussion. I wasn't ready for that kind of thing. And I just wanted to get better. But they basically bulldozed over everything I said. I wasn't comfortable. They kind of ignored me and kind of just kept trying to push what they wanted for me on.
That is unfortunate, but we can hopefully learn from that and as providers, um, hopefully try and make a change. So let me move on to the next slide. The next characteristic that we found key in our model was self-agency. And we define this as the confidence and ability to make decisions about one's health. So what does this involve? Co-creating plans, the physician, the healthcare provider, and even the healthcare team, as well, along with the patient, would sit down, figure out what the goals on either side are, and how to best reconcile them if they're at odds, or how to best merge them to make for a successful encounter. Second is encouraging patient-led goal setting. I'm not sure if you have heard about SMART goals. But these are different. It's an acronym for the goals for creating different goals. And it involves making them actionable, making them task specific. And these are really helpful when the patient is able to come in and say that I've got this set of goals. These are what I want to achieve. How can you help me achieve these? The patient will only do that if there was communication, which we discussed earlier. The last is meaningful outcomes follow. So let's hear from the patient about self-agency and leadership driving health outcomes. So a few questions for you, Charlie. Can you tell me about a time when you felt in control of your own healthcare decisions?
Yeah, so I was quite young when I first had my injury, and so I wasn't confident in myself or my care. But through actually working with some really great doctors, I was able to kind of state what I wanted for my care. I wanted like what I apologize, what I needed from my care. And so I was able to really dictate, what was what I needed for my healing and my healthcare journey.
Definitely. What helps you feel confident to speak up or share your own ideas about your care?
Yeah, so for me, what really helps is talking to my doctors about, my limitations what before an appointment, and kind of being able to state what I need from them. I need them to talk slower. I need to take time to write things down. And so what gives me confidence in that is, taking charge and being able to really dictate what I need from each appointment.
That is so valuable, actually, in my schooling. I'm currently a medical student, but we were learning about booking extra time for certain patients. And that's what we're hearing from Charlie as well. Not everything is about a 15 minutes, get in the door, see the patient, discharge them, and then bill. It's more about actually sitting down with the patient, understanding them, and if the patient is able to feel, if they're able to feel confident enough to actually let us know that, hey, listen, we kind of need a little bit more time, or we need you to slow down a little bit. That means the world because now they get better care. And as a physician, you actually make, or as a healthcare provider, you actually make a difference in their lives. Um, and the third question I have, if you could give any advice to healthcare providers about helping patients feel more empowered, what would you tell them?
Yeah, so I would say, you know, patience and honesty are the two things that have helped me the most in my care. Um, Being able to get straight answers, even if the answer is I don't know or I'm not sure, having that answer from a healthcare provider is huge. And it really builds that trust and rapport with your healthcare provider. And like we stated earlier, patience, being able to take time and slow down for a patient that needs it, is a really big game changer.
Awesome. Thank you for sharing. Um, So now we reach the last stage of our model, which is working together to mentor future generations. And we like to use this term, we as a team. And what does this mean? This means that there's the patients and the healthcare providers and the future clinicians as co-learners, such as myself, all work together and really figure out what are our goals, what do we want to achieve, and how can we best achieve this such that everyone in the encounter is satisfied. This could involve multiple different, this could be achieved through multiple different avenues. So, for example, patient mentors in medical schools and in different medical education. So, for example, having someone like Charlie come in and speak to us as students and say, this is what my goals are. This is what I want to see from you in the future. That really helps. Another is patient-led peer support groups. So for patients themselves, sometimes you can't expect them to just know that, oh, I feel empowered. Now I can ask all these questions. What if they don't know what questions to ask? They can feel empowered and not know what to ask, and that's totally okay. But when you have patient-led peer support groups, when you have people like Charlie who go and talk to different patients and tell them, these are things that you can ask about. These are how you can formulate your goals. You can put them in the form of SMART goals. You can ask your physician to book extra time for your appointments, ask them to slow down. This really helps patients understand what they can, should, and need from an encounter and ask from a physician. So I have an audience question actually. Aside from these two, how else can patients contribute to healthcare leadership and help mentor future clinicians? Ideally, I would love to hear from patients. I would also love to hear the perspective from different healthcare providers. So I'll just see in the chat if anyone has any ideas. Maybe I'll wait about 3 or 4 minutes and then we could continue. If no one has any ideas, that is totally fine as well.
Ollie, while people put their comments in the chat, I'll say as a patient, I've been asked by providers, if I feel comfortable allowing like a training clinician to be allowed in the appointment so that they can kind of see, how, the session goes. And so, I think, as a patient, like if you have those opportunities to allow a future clinician to sort of sit in on your appointment or your session, and then maybe asking questions or kind of taking that role as like a patient leader during that sort of training appointment, as I think is a good practice, just so that they can see, like, here's a patient that is really sort of taking charge and is making a plan, and hopefully the provider is sort of like modeling that as well. So I think that's just one idea that I sort of had.
That's a great idea. I had a question. Does that, as a patient, does it make you feel uncomfortable if there's a student that's just sitting there as just like eyes just staring in the encounter, and that's, or is it okay because you understand why they're there?
Patient, I've always been very understanding because they have to get their training somewhere. So I've always been comfortable, and I've always agreed. I do think that for some people, though, it might be a little intimidating. So definitely they have the right to sort of refuse to do that or not feel comfortable. But yeah, it's always been cool for me, and they have to learn. So
That is true. Um, I don't see anything in the chat right now, so I'll move on. If anyone does have any ideas of how else patients can contribute to healthcare leadership and help mentor future clinicians, I would love to hear it at the end. Um, so the physician perspective on patients as leaders. Building partnerships is not just about better care, it's about creating patient leaders. Um, when patients feel confident and supported, they can guide and inspire others. And a perfect example of that is Charlie. Being here, he's guiding the patients, he's guiding me as a student, Dr. Cam as a physician. And so there really is no bounds to the learning that can happen or the meaningful learning that can happen from patients sharing their experiences. When patients guide and inspire others, they serve as leaders, and this shapes the values, empathy, and skills of doctors who will come after us. And so this is the last point in bold. Physicians and healthcare providers must lay the groundwork today so that future doctors, shaped by past patient mentors, engage their current patients as partners in decision making. Without this partnership, healthcare will collapse because patients will not be satisfied, physicians and healthcare providers will not be satisfied, and it's a recipe for disaster. I do see a couple points in the chat that I'd like to address. Um, one person has said that I've had some of the worst, most unhelpful side comments from students observing that really derailed their health appointment. But if I demand they leave, that hurts the relationship with the main provider. This is a very valid point, and unfortunately, sometimes students they don't say what's right, or they're interfering where they're not supposed to, where it's supposed to be a learning encounter. They might say some things. I would love to hear if you're comfortable with elaborating on what things have been said, and maybe this is something that we can include in our model for how we can create partnerships without having patients feel derailed. Another comment is, as a patient, I try to encourage student clinicians to ask me questions. They're becoming the experts in their field while I am an expert on me. I love how that has been said, that you are an expert on you, which is very true. And provider's not an expert on you, the student's not an expert on you, but they're going to be experts in their field. That is very beautifully said. I think a starting place is training doctors that people with disability live lives are as valuable as those of non-disabled people. Here's one article on the attitudes, and there's an article shared in the chat. I'll definitely be saving that to read later. And actually, in the curriculum that we have in Toronto, we have a mandatory part of our curriculum where we have to, as students, go into a center for disabilities and interact with those patients in, of course, a very controlled environment and get their perspective, see what they want to hear. And I think just hearing from that, from you on your experience with a student making very rude comments, I think something like that needs to be implemented in medical education throughout the world, where students, before they actually go and sit in on encounters, they're exposed to the different perspectives, and then it's up to them, right, whether they take it or not, but then that they need to be exposed. And if they don't take the perspectives of others, then unfortunately, that's not going to be very good for healthcare. I see another point. I also think it's important to strike a balance. A patient's first priority is to ensure that they're taking care of their health. I think it's also important for clinicians to take active efforts to learn about how to compassionately interact with patients while optimizing with in-person interactions. Very true. I also think it's important to strike a balance. So this is the same comment. It is extremely true. The patient needs to prioritize themselves and their health first. And as patients in this meeting, I would love for you to know that it's okay if you decline for a student to be there. If you've had negative experiences or if this is something sensitive, I've been told you can't be in this encounter because the patient doesn't feel comfortable. There are no hard feelings because as it was beautifully said, a patient, they have to take care of themselves first. Another comment, as a patient and having a fellow make errors is also a concern. I would hope your work would be applied to fellows also. This is a very good point that fellows are also in their training, though I think the fellow, I'm not sure if it means the same throughout the world, but in Canada, a fellow is someone who's completed their residency and now they're just doing some extra specialization. They're still in training and they can still make mistakes, which is very true. And I think another point that I thought of when I read this is that when mistakes are made, it's important that we use communication, as we mentioned earlier. Use the quality of communication to tell the patient that, hey, look, there was this mistake that was made. If there were an OR room and the patient is sedated and something happens, say it doesn't affect the health. It's still important to be able to tell the patient that this is what happened. These are the steps that we took. Because after all, the patient is an expert on themselves, as was beautifully said earlier, and they need to know what has happened to them. Let me move on, and I'd love to hear more comments. So the key messages. Partnerships based on communication and a self-agency build trust in an encounter. Trust fosters empowerment of the patient. Empowerment fuels leadership, and leadership teaches us and our future generations to be better clinicians. And this was our model in short. So thank you very much for your participation. This is our website if you would like to click on them and learn more about us. We do have some time for questions.
So please put the website. We have a comment or a request? Can you please put the website link up again? I'm assuming the previous slide with your information.
Yes. Let's just wait for this to. Oh, yes, here we go.
Awesome. So while people sort of gather their thoughts and put their questions in the comments, I actually have a question. So, I know you talked a lot about sort of the patient provider partnership. And so, I think we've all experienced that, that has kind of been an evolving thing, over the last several decades. And so lately in the last decade or so, we've really seen a rise of virtual care. And so how does the virtual setting and virtual appointments, how is that sort of factoring into this sort of patient provider partnership and building rapport?
That is a very good question. And I had done some research on this actually. Not all patient encounters and not all patients are suitable or suited for virtual care. And that is really important in the triage step. So when a patient comes in, I think the first encounter should never be a virtual encounter. That is not how you build rapport. You see the patient, you interact with them, unless, of course, this is what the patient has voiced that they really want. And then after that interaction, it's important for the healthcare provider to propose this idea to the patient. Do you think that a virtual encounter would be appropriate for you? Would you like it? Are there any barriers? If they say yes, what are the barriers to a virtual encounter? If say they're not that technologically savvy, is there any way that we can help provide them with a center where they can go to access a phone? What can we do to help them with maybe a quieter space where they can take the encounter, etc. So it's really important for that communication piece to be there to make sure that virtual encounters are successful.
Awesome. Thank you so much. I'm just waiting to see if anyone else has any questions that they can put in the chat.
All right.
Oh, so we have a question that's come in from Amber. So have you experienced resistance to this work?
So far there has not been any resistance to this work, but I would love to ask Charlie if he has experienced resistance for when he has spoken at these different gatherings about his experiences.
I don't think I've experienced any kind of major resistance. Um, there's always, the question of, like how the work has impacted me. And so I'm always like happy to share my perspective with people. And sometimes I get a little bit of uh, like a little bit of, I wouldn't say side eye, but a little bit of confusion as to how my role is taken into account and how important my role is, sorry, in this work. And I'd say that's like a little bit of resistance, but nothing major.
Thank you. Another question. What role can caregivers play in helping build rapport with patients and doctors? I love this question. This is actually what I wanted to expand research on, is the role of caregivers in helping to build rapport with patients and doctors. And I think there's two elements to this. One is where the caregiver is intimately involved in the encounter because they might be a translator, and another is when the caregiver is a bystander to the encounter and there for their support. So when they are a translator, it's quite it's quite difficult for them to like they can't provide their own perspective. They're just there to be the intermediary between the healthcare provider and the patient. But they can still help build rapport by explaining, for example, if there's a physician and there is a patient from different cultures, there may be a disconnect in terms of certain phrases that are used or how they translate. And it's really important for the caregiver over there in the role of a translator to maybe explain, not literally or not literally define what the physician has said, but rather explain it in a way that the patient might understand it. The other side of this is where the caregiver is just the bystander. And over here, it is really helpful for the caregiver to give the patient space and also I like fully be frank and ask, is it okay if I stay here? Sometimes as a caregiver, we might make, I myself, I'm a caregiver for my grandma, and sometimes I may make an assumption that it's okay for me to sit into the encounter because my grandma needs help, or my grandma who should prefer to me to be there because she loves me. But sometimes she'd prefer to do it alone. She'd prefer to just be with the physician. And so I think just always making sure that you are doing what the patient wants. And then from the physician's end, it's also really important that if you see a caregiver, to not just assume that that caregiver is okay to be in the interaction. I was actually just with a physician a couple of days ago, and she explicitly asked the caregiver to translate to the patient, is it okay if I am your translator? And I think that builds wonder for the patient to trust the physician. It's that they actually are looking out for me. Um, Charlie, do you have anything to add?
I don't have a lot of caregiver experience myself. And throughout my care, both I'd say unfortunately and fortunately, I didn't really have a caregiver in my own health care, which did force me to kind of grow as a patient myself and gain confidence. But it what my parents were slightly involved in my care, and from their perspective, I'd say like they had difficulty kind of giving me space to be my own patient. And so kind of having a caregiver have the awareness of when they do need to step back or when they need to take charge is a big contributor to a person's healthcare.
All right. There's another question for Alice. I think that she has logged off because she has another commitment right now. Let me see if I would be able to answer it. In your experience as a practitioner, is the movement towards more patient-centered care affecting the dynamics we've been discussing? Oh, well, I'm not an independent practitioner, so I'd be unable to answer this, but I might be able to copy this and maybe I can ask Dr. Cam another day. Let me just paste this into my notes to make sure I can ask her this question. And then I see something else coming in. Repeat, relatedly, as we heard on Tuesday afternoon, there are resources and toolkits that have been developed to support the understanding and fully informed consent and participation of people with cognitive issues in research. Has the team encountered any of these resources and used them? That was a painful story Charlie told about being pressured into participating in a study. That is another question for Dr. Cam that I would be unable to answer, unfortunately. How can clinicians reconcile the pressure to complete documentation at the point of care with the need to build rapport by maintaining eye contact and being engaging in conversation and being fully present with the patient, as Charlie described? What implications does this tension have for a healthcare system driven by productivity metrics? I think this is something that I've seen, so I'd be able to provide my input on this. But when let me read the question a bit loudly. How can clinicians reconcile the pressure to complete documentation at the point of care with the need to build rapport by maintaining eye contact, engaging in conversation, and being fully present with the patient, as Charlie described? What implications does this tension have for a healthcare system driven by productivity metrics? And I think this is so important. But when we look at what the healthcare system that's driven by productivity metrics, you cannot drive a system that does not exist. And that is what we'll trend towards if there is a lack of this eye contact, this rapport building, etc. And so, from the clinician perspective, it's hard to say that, oh, we're going to be booking a 30-minute appointment, 45-minute appointment, where we normally book a 15-minute or 10-minute. And what's the implication for the other patients that we have to see? There's always the option of shortening reducing the roster. And now there's actually care teams where physicians, they work together in a team, and they see patients as the patients come in. So they won't really know. The patient doesn't see the same physician every time they see someone from the team. And I think that's really helpful, that if you're having a bit of a longer day, a team member can take a few more patients and you can see them. And so there's always a balance with this teamwork that can be done. And then it's always hard that we are driven, at least in Canada, it's driven by the billing, and billing is done based on the patient. But then we really have to look into ourselves and understand, why are we doing this? Are we doing this for billing and for productivity and efficiency? And are we McDonaldizing? I'm not sure if you're familiar with the McDonaldization phenomenon in sociology, but are we McDonaldizing healthcare? Or are we treating healthcare as what it should be, a very sacred place where patients and physicians alike are there for a common goal of healing? Another thing, the last few times I was in the ER for severe health crashes, the hospitals were owned by megacorps, and the nurses often didn't have time to engage with me at all. Straight to the room, computer to chart, type, 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 and then gone. The only things that they checked was maybe if the IV was still running and pulling numbers off the vitals and tracking machine. This is so unfortunate, and I would like to ask you, how do you feel when that happens? Uh, I can guess that you don't feel so great, but I'd love to hear from you. You feel dehumanized. That I'm so sorry for that. But this is exactly what we want to avoid with teaching providers through our research, teaching providers, teaching patients how to feel empowered, how to empower each other, such that we're not in a rush. We don't always need to be in a rush to chart, type. Taking a minute to breathe, taking a minute to just listen, it doesn't add much to much time. It doesn't add much inefficiency. And I'm sure that an example that we can all relate to is when we're late on the road and we try to switch lanes like 5, 6 times to get ahead of someone, only to be stopped at a red light, where everyone behind us comes and they're stopped at the exact same red light. So really, by rushing and doing all these hash things, it doesn't help. And that is something that's really hard to make a lot of people understand, but it's something that we will continue to try to do because it is so important. We'll just
I think so, but I will say really quickly, I love that phrase that you used, the what is it, McDonaldized?
McDonaldization,
Yeah,
yeah.
I've never heard that, but that actually is perfect. So I've seen just some comments really praising this presentation. I was thinking I really loved this format where you and Charlie were kind of talking and reflecting on your different perspectives. So I just think this has been a really good presentation. I think and really every person, because every person interacts with the healthcare system at some point in their life, can really relate to this. And you all shared some really good insights.
Thank you. That was one of our goals, is that we're preaching all of this about understanding the patient and making sure to empower them. But how can we have a presentation without them present? Right? It
Exactly.
seems
Yeah,
contradictory. Um,
exactly. Yeah. So I'll just give it a minute just to see if anyone else has any other lingering questions or comments.
Thank you for everyone's comments.
So thank you again for your amazing presentation. And as always, we are recording this. So if anyone who is attending this, wants to revisit anything that was said in this presentation, these materials will be available in the coming weeks. And so you can check those out for sure.